Bismillahirrahmanirrahim. Today we are going to start with the pathology of the heart. In this lecture, we are going to discuss the ischemic heart disease. So what is the ischemic heart disease? This is a group of closely related syndrome resulting from the myocardial ischemia. So what is the myocardial ischemia? When there is imbalance between the supply, that is the perfusion, and demand of the heart for the oxygenated blood, it results in the myocardial ischemia. Ischemia implies not only the insufficiency of the oxygen but reduced availability of the nutrients and inadequate removal of the metabolites. Isolated hypoxia due to cyanotic heart disease, anemia, or advanced lung disease is less harmful. So what are the types of ischemic heart disease? 90% it is due to reduction of the coronary blood flow as a result of atherosclerosis or other causes, including the arteritis or an embolism. Ischemic heart disease, it is also termed as a coronary artery disease. There are the main four types of the ischemic heart disease. One is the myocardial infarction, other is the angina pectoris, other is the chronic ischemia with the heart failure, and the fourth one is sudden cardiac death. Again, I am going to repeat it that there are the four types of the coronary heart diseases. One is the myocardial infarction, other is the angina pectoris, and third one is the chronic ischemic heart disease with the heart failure, and fourth one is the sudden cardiac death. There are the certain conditions which can aggravate the ischemia, including the increased demand, that is the hypertrophy of the muscles of the heart, diminished oxygen supply, that can occur in case of the shock or the hypoxemia, or increased heart rate. The rate of detectable ischemic heart disease depends upon the number of the arteries which are involved, then the distribution of the artery which are being blocked, and then the structure of the atherosclerotic plaque, whether it is the complicated one or uncomplicated one, and up to what extent it is blocking the lumen of the artery, that is the degree of the narrowing of the artery. So what is the acute coronary syndrome? It is initiated by conversion of a stable atherosclerotic plaque into the unstable plaque. So this is basically the disruption of the plaque or acute plaque changes which can cause the symptom of acute coronary syndrome. The clinical manifestation of the ischemic heart disease are unpredictable. Elderly with advanced atherosclerotic plaque, they may be asymptomatic, while a young patient with the moderate obstruction can have myocardial infarction or sudden cardiac death. So the ischemic heart disease, this is a leading cause of death in the USA. Annually, 1.5 million per year people are affected by the ischemic heart disease, and 50% die before reaching the hospital. The decline in the number after 1963 by 50%, and it is because of the introduction of the preventive measure which can prevent the chances which can prevent the progression of the atherosclerotic plaque and development of the atherosclerotic plaque. So these preventive measures can be the reduction of the smoking, controls of the cholesterol levels, control of the hypertension, change in the lifestyle, and adoption of the healthy lifestyle. Furthermore, there are different new diagnostic and therapeutic advances along with the thrombolysis and the angioplasty, stent placement, and the coronary artery bypass grafting. So what is the pathogenesis of the ischemic heart disease? In ischemic heart disease, there is basically the diminished coronary artery perfusion relative to the demand by the myocardium. So there's a reduced demand, so there's reduced supply with the increased demand. So there's a complex and dynamic interaction among the fixed atherosclerotic narrowing. Then if there's a thrombosis with the platelet aggregation, and there's a vasospasm. Clinical manifestation, it can be because of the chronic fixed obstruction to the flow or acute plaque changes. If the obstruction is 75% or more, it can cause a symptomatic ischemia during exercise. And if the obstruction is up to 90%, it can cause stenosis or symptoms even at rest. So all the coronary arteries can be involved, but usually the first several centimeters of the left anterior descending and left circumflex arteries are being involved. There can be involvement of all along length of the right coronary artery, but the atherosclerosis of the intramural branches is rare. So atherosclerosis mainly involves the main coronary arteries, that is the left anterior descending, left circumflex, or right coronary arteries. So what is the role of the acute plaque changes? In most patients, acute coronary insufficiency is precipitated by the abrupt plaque changes followed by the thrombosis. The triggering events which is going to cause these acute plaque changes, these can be complex and poorly understood. There can be the intrinsic influences, that is the changes within the plaque itself, or extrinsic factor like the changes in the blood pressure and platelet activity. Initiating event in the disruption, this can be the rupture or fissuring inside the plaque, erosion and ulceration of the surface of the plaque, and hemorrhage inside the plaque. Here in this diagram, you can see that this is a coronary cut section of the coronary arteries. You can see there's an intimal lesion, that is the atherosclerotic plaque, and there are the sudden plaque changes, as there is in the A part of the picture. You can see there is the ulceration of the surface of the plaque, phase superimposed thrombus formation and platelet aggregation, and then in the C you can see that in this whole plaque there is actually the thrombus formation with the help of the special stain. Then in the lower part of the figure, you can see that there is a thrombus formation along with the hemorrhage inside the plaque. So what is a vulnerable plaque? Vulnerable plaque is that plaque which has tendency or which has vulnerability because of its thin fibrous cap, few smooth muscle cells in the intima, and clusters of inflammatory cells, a large area of the foam cells with the extracellular lipids. So if a plaque, it is having more lipid, more macrophages, less smooth muscle cells and thin fibrous cap, this plaque has more chances to undergo the abrupt or sudden plaque changes. So as you know that plaque is having two components. One is fibrous cap with the and shoulders, and other one is the core. The most of the surface changes, that is a fissuring or ulceration, these are going to occur at the junction of the fibrous cap with the adjacent tissue. The fibrous cap undergoes continuously remodeling in the form of collagenization because of the action of the metalloproteinases. The use of the statin, they are going to stabilize the plaque by reducing the lipid content and the inflammation. The extrinsic influences like the adrenergic stimulation and hypertension and vasospasm, they also influence the plaque dynamics, and they are going to change the morphology of the plaque suddenly. So what is the role of inflammation in the plaque changes? The inflammatory process plays an important role in the atherosclerosis because they are going to secrete these certain inflammatory markers in the form of the chemokines and adhesion molecule. Therefore, these inflammatory cells, they are going to recruit more lymphocytes and more macrophages. So the measurement of the C-reactive protein, which is a marker of the inflammation, so it can be used to predict the risk of coronary artery disease in any patient, because if there is more inflammation in the plaque, the patient can have the more level of the C-reactive proteins, and these C-reactive protein are acute phase protein. These can be used to measure the risk of the coronary artery disease in any certain patient. The thrombitis can completely or partially obstruct a blood vessel having an atherosclerotic plaque. If the thrombus is going to completely obstruct the coronary blood vessel, this is going to result in the myocardial infarction. And if there is a partial obstruction because of the thrombus formation, the patient usually have the sign and symptom of angina, unstable angina pectoris. The thrombi, these can be embolized, and the small fragment of the emboli, this can be found in the distal circulation. So vasoconstriction at the site of the plaque. There are the multiple causes of the vasoconstriction. These can be the adrenergic agonist, or the substances which are released from the activated platelets, or because of the impaired secretion of the endothelial relaxing factors, or the other chemical mediators of the inflammation. These all can cause a vasoconstriction. The vasoconstriction, it can cause a mechanical force to disrupt the plaque, which can aggravate the plaque, which can increase the plaque size because of the disruption of the surface, and it also going to cause the narrowing of the lumen of a blood vessel. So what is the angina pectoris? This is a symptom complex which is characterized by a paroxysmal and recurrent attack of the substernal and precordial chest discomfort or pain that is caused by the myocardial ischemia falling short of the inducing cell necrosis or infarction. Again, I am going to repeat this, that in the angina pectoris, there is ischemia, but there is no cell necrosis. So there is a pain, precordial chest pain. This is because of the cell ischemia, not because of the cell necrosis. So there is a varying combination of increased myocardial demand and decreased perfusion. Because the angina pectoris can occur because of the fixed stenosing plaque, or it can occur because of the sudden plaque changes, and because of the thrombus, which is not completely occluding the lumen of the blood vessel. It can occur because of vasospasm. It can occur because of the platelet aggregation and activation, and it can occur because of this embolization, which can cause the narrowing of the lumen of the blood vessel. Now there are the multiple subtypes of angina pectoris. These can be the stable angina. In the stable angina, there is a reduction of the coronary perfusion to the critical level by the chronic stenosing atherosclerotic plaque. So there is increased demand by the physical activity, or because of the emotional excitement, or because of other causes which can increase the workload, but at the rest the patient is having no symptoms of the angina. It is relieved by taking the nitroglycerins. So what are the other types of the angina pectoris? It is known as a Prince metal variant angina. It is episodic angina which occurs at the rest because of the coronary artery spasm, and ECG it is manifested as elevated ST segment. It is indicative of the transmural ischemia, and it is unrelated to physical activity. It responds to the nitroglycerin and calcium channel blockers. So here in this picture, we can conclude or summarize what we have learned previously. In the right extreme left hand side, you can see that there is an unremarkable coronary artery without the obstruction of the lumen. Whenever there is a development of atherosclerotic plaque, it is going to cause the narrowing of the lumen. It is known as the fixed coronary obstruction. In case of the fixed coronary obstruction, you can see if the patient is having a physical activity like in the form of the exercise, or if there is the increased demand, it can cause the symptoms of the angina, that is a stable angina. If there is any changes over the surface of this plaque or plaque disruption, it can cause the activation or adhesion of the platelets. These platelet adhesions and activation, it can cause the formation of a thrombus over the surface of this plaque. Now this thrombus formation and our hemorrhage inside the plaque, it can cause a complete occlusion of the lumen of this blood vessel. This complete occlusion, can cause the sign and symptom of the myocardial infarction, or it can present a sudden cardiac death. Now what is going to happen if this thrombus, it is incompletely occluding the lumen of this coronary blood vessel? If this is incomplete occlusion, then there are two or three chances. One chance is this, that the patient can present with the sign and symptom of unstable angina. Patient can have this sign and symptom of the subendothelial myocardial infarction, or patient can have the sudden cardiac death, depending upon the level, the type of the coronary vessel which is involved, and depending upon the level of the obstruction of the coronary artery. On the other hand, if there is a slow progression in the size of an atherosclerotic plaque, and it has critically stenosed the blood vessel up to the 90%, again this is a fixed coronary obstruction but of the severe level. So these patients are going to usually present with a chronic ischemic heart disease. So what is the myocardial infarction? The myocardial infarction, it is also known as the heart attack. It is the death of the cardiac muscles because of the ischemia. This is the leading cause of death in the USA and other industrialized nations. It is going to affect 1.5 million people per year, and 0.5 million people die, and 0.25 million people, they are going to die before reaching the hospital. So what is the myocardial infarction? It has two types. One is the transmural and other is the subendothelial. In the transmural, the full thickness of the myocardium, it is involved, and there is the death of these myocytes. And it is really associated with the coronary atherosclerosis and with the acute plaque changes or with the superimposed thrombus formation. So there is a complete occlusion of the coronary artery resulting in the ischemia of the cardiac muscle, resulting into death of those cardiac muscles. What about the subendocardial infarct? When the infarct is limited to the inner one-third or inner two-thirds of the myocardium, it is known as a subendocardial infarct, and this is the most vulnerable part of the heart because the supply of the heart, it is coming from the outer surface. So the inner part of the heart, it is most vulnerable part of the heart, vulnerable from the ischemia. Again, it can result from the acute plaque changes or the plaque disruption and because of the thrombus formation. And then there is a reduction of systemic blood pressure that is going to occur in case of the shock. The risk factors of those atherosclerosis are similar with the myocardial infarction, and they can occur at any age, and they are going to increase with the increasing age. Under the age of the 40, there are the 10% chances of development of the myocardial infarction, but after the age of the 40, that is under 65, there are 45% chances of the development of the myocardial infarction. Men are at more risk development of the myocardial infarction as compared with the female, but after the menopause, the patient, both the sexes have the similar risk. As we all know that the complete coronary occlusion, it is going to occur because of the interaction between the atherosclerotic plaque and because of the sudden plaque changes, because of the platelet resulting into the platelet activation, formation of superimposed thrombus or spasm in the involved coronary arteries. And so the sequence of events are there. There is sudden change in the morphology of the plaque, so that the subendothelial surface or collagen is exposed, and the platelet get activated, and they become adhesive to the site of the subendothelial collagen exposure. And they are going to release the certain substances which is going to cause a vasospasm. And once the vasospasm is there, there's a further reduction in the lumen of the artery. And these little adhesions are going to cause the thrombus formation at the site of the endothelial injury. 10% cases of the myocardial infarction, these are not associated with the atherosclerotic thrombus or disruption. Their main mechanism is vasospasm or the emboli formation over the surface of the emboli in the coronary arteries. Some patients have the unexplained mechanism. So this the loss of the blood supply to the heart, it is going to cause the both functional, biochemical and morphological changes. The earliest biochemical change is the cessation of the aerobic glycolysis, and there is the anaerobic glycolysis. It is going to start with the result a decreased ATP production and increased lactic acid accumulation. The myocardial necrosis, it is going to occur within the 30 minutes after the ischemia, and after 2 to 4 hours there is extensive damage, and there is complete necrosis by the 6 hours. If you are going to restore the blood supply of the ischemic heart muscles by the thrombolysis, these muscles can be salvaged and the size of the infarct can be reduced. So here this is an important table, and in this table it is going to explain the biochemical events which is going to occur at the level of in the myocardial muscle after the ischemia. Once there is ischemia, the supply of the ATP is reduced within the seconds. Functionally, there is a loss of the contractility of the myocytes. It is going to occur less than 2 minutes. And The ATP, it is going to reduce up to the 50% of the normal within the 10 minutes after the onset of the ischemia, and it is only available up to 10% of the normal after the 40% of the ischemia. So irreversible injury, it is going to occur after the 20 to 40 minutes of the onset of the ischemia, and the microvascular injury, it is going to occur after the it will take more than 1 hour after the start of the ischemia. Now the ischemia of the ischemic size is location and morphological features. They depends upon multiple factors. For example, they depend upon the location, location of the occlusion, severity of the occlusion, and rate of development of the occlusion. Furthermore, they also depend upon the size of the vascular bed which is perfused by the obstructed vessel, then the duration of the occlusion, and then the metabolic demand of the myocardium which is being at a risk, then the extent of the collateral blood supply to that affected area, then the site and severity of the coronary spasm, then the alteration of the blood pressure, heart rate, and rhythm of the involved myocardium. So the area which is being most commonly involved in case of the obstruction, this is the left anterior descending artery territory that is going to affect the left ventricle near the apex, anterior ventricle septum, apex circumferentially. If the right coronary artery is involved, then it is going to affect the inferior and posterior wall of the ventricle, posterior ventricle septum, and if the circumflex coronary artery is involved, it is going to affect the lateral wall of the left ventricle. In this picture, you can see that there is an occlusion in the left anterior descending artery. So the area which is being involved, it is the apex of the left ventricle, and depending upon the time, the ischemia, it become more evident. Initially at the 0 hour, grossly you can't see any change or any ischemic zone in the affected area, but with the passage of the time, you can see that the ischemic zone, it is become more apparent, and initially it becomes more apparent in the subendothelial area, and eventually it is going to involve the whole thickness of the myocardium. At the earliest, in the earlier time, the changes because of the ischemia, these are not evident, but with the passage of the time, they become more apparent. So after the ischemia, within 12 hours, there are no gross changes. And with the use of a special dye, that is the triphenyl tetrazolium chloride, or TTC, these changes can be visualized within the 2 to 3 hours. And after the 12 hours, the affected area, it is going to show a red-blue hue. In this picture, you can see that after the application of TTC, the affected area, it is going to show a pale appearance. So this is a table which is going to show the relationship between the time and the gross and the microscopic appearance of the myocardium, which is affected with the ischemia. So after the ischemia, within 18 to 24 hours, the myocardium become pale. After the 24 hours and up to 72 hours, the pale area become somewhat hyperemic. Then after the third day and up to the 7 days, there is the hyperemic border with central yellowing. And after 10 to 21 days, there is the maximum yellow area, and it is a soft central area with the vascular or hyperemic margins. And at the 7th week, you are going to see the white area of the fibrosis at the zone of the ischemia. So what is going to occur microscopically after the infarction? After the 3 hours, within 1 to 3 hours, the myocardial fibers, they become wavy. The fibers within the myocytes, they become wavy. So after 2 to 3 hours, there is a staining defect which can be detected by the tetrazolium, TTC, or a basic fusion dye. After 4 to 12 hours, there is the coagulative necrosis with the loss of the cross striation of the myocytes, and there is the appearance of the contraction bands within the myocytes. There is the edema in the affected area of the hemorrhages, and early neutrophilic infiltrate. So in 18 to 24 hours, the coagulation necrosis, it is going to continue. There is the pycnosis of the nuclei become darkly stained, and there are the marginal contraction bands within the myocytes. After 24 to 72 hours, there is the total loss of the nuclei now, and the striation along with the heavy neutrophilic infiltrate can be seen in the affected areas. After 3 to 7 days, the macrophages and mononuclear cells, they are going to be, infiltrate the affected area, and there is also the vascular response, a new vascularization at the margins. So after 10 to 21 days, there is maximum vascular response, a new vascularization in the affected areas, and in the 7th week, you are going to see the colonization or the fibrosis. So these are the pictures which are going to show the microscopic changes after the ischemia. So here you can see that in the left-sided picture, in the left part of this picture, you can see that these is the ischemic myofibers, and you can compare with them with the normal myocytes. The normal myocytes, they have a central blue nuclei, while the ischemic fibers, these one are contracted. These are more pinkish, and these are contracted one. And on the right side of the picture, you can see that these myocytes, these have the contraction bands within the cytoplasm with the loss of the nuclei. Further, you can see the small areas of the hemorrhages within these myocytes. So after the 4 days, you can see that these myocytes, they have completely lost of their nuclei, and there is a neutrophilic infiltrate. And the gross picture of the myocardium, it is going to show the upper part of this picture. You can see there are the paler areas, which is going to see the at macroscopic level. You can see that this myocardium is having the neutrophilic infiltrate. So with the more passage of the time, the neutrophilic infiltrate is being replaced with the foamy histiocytes and with the plasma cells and the lymphocytes. And the affected myocardium is having more liquefied area, which is being shown in the lower part of this picture. So after the period of 1 month to 1 year, there is the progressive fibrosis or colonization of this affected myocardium. As you can see in this picture, that with the use of the trichome stain, there is trichome stain is going to show that there is more blue colored stains collagen, and with the passage of time, the affected area of the myocardium, it is the myocytes are replaced with the collagen, and it is there is more area of fibrosis. So in this picture, you can see that after the myocardial infarction, there is the release of the myosin troponin from the actin filament, and there is also release of the enzyme, that is the CKMB, creatine kinase MB, and these are being released into the main bloodstream. And with the help of these markers, which are the marker of the infarction or ischemia, you can detect the myocardial infarction as early as possible. See, so the troponin I, CKMB, and myoglobin, these can be used to detect the ischemia in the blood. Then there's the infarct modification by the reperfusion. The most effective way to salvage ischemic myocardium is by restoring the tissue perfusion. There are different methods by which you can restore the blood supply to the affected myocardium. These can be the thrombolysis, these can be the balloon angioplasty, or these can be the cabbage. So the reperfusion, once you have reperfused the area, there is again the supply of the oxygen is restored to the affected myocardium. But the myocardium is not fully functional because of the previous ischemia. So there is the calcium influx to the affected myocardium, and this influx of the calcium, it can produce the arrhythmias. It can cause the myocardial hemorrhages and with the contraction. So the restoration of the blood flow to the affected myocardium, it can limit the infarct size. The first 3-4 hours after the infarction, this is a critical one. The reperfusion to the affected myocardium, it can cause a hemorrhage in the affected area, and the necrotic myocytes, they can develop the contraction band because of the increased supply of the calcium to the affected myocardium. So the reperfusion at the site of the injury, it can bring more amount of the oxygen, and this amount of the oxygen, it cannot be fully utilized by the injured myocytes, which can result in the production of the oxygen-free radicals, which can cause even more damage to these injured myocytes with more apoptosis, and there is a microvascular injury with the swelling of the endothelial cells. So here in this picture, you can see that with the passage of the time, there are different gross appearance of the injured myocardium. At the apex, where where there was an area of the ischemia or infarction, if the reperfusion it is going to occur within less than 20 minutes, there's only the area of yellowness. But if the reperfusion occurs within 2 to 4 hours, there is a partial salvage with the central areas of the hemorrhage and the outer area of the yellowness. And if there is a complete occlusion with no reperfusion, then there is a complete necrotic area. So diagnosis of the myocardial infarction, it can be diagnosed with the symptoms by biochemical test and with the help of the ECG. The patient is having the weak rapid pulse with the profuse sweating and chest pain and with the history of the dyspnea. ECG changes cannot be detected in 10 to 15% of the population. In the lab investigation, the troponin T and troponin I, these can be detected as early biomarkers of the infarction. They are going to rise within 2 to 4 hours of the infarction. They reaches with their peak within the 4 hours and remain elevated for 7 to 10 days. CKMB, it is going to rise after 2 to 4 hours, peak about 24 hours, and return to the basal levels after the 72 hours. Other investigations like echocardiography, radionuclide angiography, or thallium scan, and perfusion scintigraphy or MRI, they can be used to detect the occlusion of a coronary artery. So what can be the complications of the myocardial infarction? The complication of the myocardial infarction, these has been reduced because of the better management. Only 3 by 4 patients have one or more complications. First of all, complication is contractile dysfunction, left ventricle failure with the hypotension, pulmonary congestion and edema, and respiratory impairment. It can occur. 10 to 15% of the patient, they can develop the cardiogenic shock, which having 70% mortality. The patient after myocardial infarction, they can develop the arrhythmias which is responsible for sudden cardiac death. And the arrhythmias can be sinus bradycardia, it can be the heart blocks, it can be tachycardia, it can be ventricular fibrillation. The other complication can be the myocardial rupture. After the ischemia, the myocardium become weak because of the necrosis of the myocytes and because of the inflammation. The chances of the disruption or rupture are at the highest at the 3 to 7 days after the infarction. The rupture of the myocardium can occur of the ventricular wall, which can lead to the hemopericardium, which can lead to the cardiac tamponade, and the risk factors are if the patient is having advanced age, female gender, and history of the hypertension without any hypertrophy. The rupture of the ventricular septum, it can occur and it can lead to the left to right shunt. Rupture of the papillary muscles, it can occur with the acute onset of MR or mitral regurgitation. So in this picture, you can see that the rupture of the myocardium can occur. It can involve the wall of the heart, or it can involve the papillary muscles of the valve. Here in this picture, you can see the rupture has been occurred and it is going to cause the cardiac tamponade, that is the collection of the blood within the pericardial cavity. The other complication of the myocardium after the ischemia. This can be the pericarditis. This can be the fibrinous one or hemorrhagic one. It's going to occur 2 to 3 days after the transmural myocardial infarction, and it is the epicardial manifestation of the underlying myocardial inflammation. There can be the mural thrombus formation, and there's the endocardial damage and mural thrombosis with the danger of the thromboembolization. So here you can see that there is the formation of the thrombus within the cavity of the heart, and it can be embolized to the distal circulation. So after the myocardial infarction, the wall of the heart become weak. So there is the aneurysm formation at the weakened area, and this is a true aneurysm. But the aneurysm can be false one, in which there is a rupture of the heart weakened area with the leakage of the blood into the pericardial cavity, and it is going to communicate from a hematoma, which is communicating with the ventricle cavity itself. So this aneurysm can lead to the mural thrombus formation. It can cause a heart failure, arrhythmias, and sometimes the aneurysm they don't rupture, sometimes they can rupture. So in this picture, you can see that there is the aneurysm formation with the dilatation of the wall of the heart. The prognosis of the infarct, it depends upon the infarct size, site of the infarct, functional thickness of the myocardial which is being damaged. Large transmural infarct, they have high chances of the cardiogenic shock, arrhythmias, and late congestive heart failure. The interior transmural infarct, they have the high risk of the rupture, and with the expansion of the infarct, formation of the mural thrombi and the aneurysm. In chronic ischemic heart disease, this is insidious onset of congestive heart failure. After ischemic heart disease, some patients don't have the symptoms of the ischemic heart disease. Morphologically, the heart is enlarged, heavy, with left ventricular hypertrophy and dilatation, and moderate severe atherosclerosis. And if you see grossly, that there are the gray-white areas of the scarring and healing, with the focal thickening and fibrosis of the endocardium. So what is the sudden cardiac death? This is the unexpected natural death due to the cardiac disease with or without pre-existing cardiac disease, and it is occur within less than 1 hour to 24 hours. It can be a first clinical manifestation of ischemic heart disease, or it can be a part of the complication of the ischemic heart disease. It is going to affect 0.3 to 0.4 million people in the US annually, and is more common in the young as compared to the older one. Mostly it is because of the arrhythmias. So beside the chronic heart disease, other causes of the sudden cardiac death, it includes the congenital coronary artery abnormalities, aortic valve stenosis, mitral valve prolapse, myocarditis, dilated and hypertrophic cardiomyopathy, pulmonary hypertension, and abnormalities of the cardiac conduction, and it can be associated with the isolated hypertrophy of the left ventricle. Arrhythmias can occur in the absence of the structure abnormality of the cardiac tissues, and arrhythmias can occur as a part of the autosomal dominant long QT syndrome, that is Romano-Ward syndrome, which causes heightened cardiac excitability, and there is a mutation in the sodium and the potassium ion channels. So what is the hypertensive heart disease? In the systemic hypertension, the hypertrophy of heart occurs as an adaptive response to overcome the pressure overload. What is the criteria to diagnose the hypertensive heart disease? If there is the left ventricular hypertrophy, that is a concentric one, in the absence of the other serious pathology, and it is associated with the hypertension, that it is known as the hypertensive heart disease. It can occur even with the mild hypertension, which is prolonged one, and it can lead to the ventricular hypertrophy. The left ventricular overload hypertrophy, if the wall is more than 2 centimeter thick and weight is more than 500 gram, then it is known as the left ventricular overload hypertrophy, and it can also lead to the left atrial enlargement. Patient have increased chances of development of atherosclerosis, and with the progressive ischemic heart disease, congestive heart failure, progressive renal failure or stroke, and there is a high risk of sudden cardiac death. So here in this picture, you can see that the interventricular septum wall and the wall of the left ventricle, it is highly thickened as compared to the wall of the right ventricle, indicating the left ventricle hypertrophy, and this is the concentric one, which is indicative of hypertensive cardiac disease. So what is the carpulmonale? This is consist of right ventricular hypertrophy, dilatation, and potential failure secondary to the pulmonary hypertension. The right-sided counterpart of this is basically the counterpart of the left-sided hypertensive heart disease. The left-sided hypertensive heart disease eventually put increased pressure on the pulmonary vasculature, which can lead to the right-sided heart failure. The diseases of the left heart are the congenital heart diseases. If they have been excluded, then it is known as the carpulmonale. Causes can be the multiple due to the diseases of the pulmonary parenchyma itself, pulmonary vessels itself, pulmonary atrial constriction, or disorder affecting the chest movements. So these are the causes of the carpulmonale, that is the failure of the right side of the heart. It can be because of the diseases of the pulmonary parenchyma, like the chronic obstructive pulmonary diseases, or diseases of the pulmonary vessels. It can be because of the disorders causing the defective chest movements, or disorders inducing the pulmonary atrial constriction, like the metabolic acidosis, hypoxemia, and chronic altitude sickness, obstruction to the major airways, and idiopathic alveolar hypertension. Carpulmonale, it can be acute or it can be chronic depending upon the suddenness of development of the pulmonary hypertension. Acute, it is going to follow the massive pulmonary embolism, and chronic one, it is because of the prolonged pressure overload due to obstruction of the pulmonary arteries or arterioles or septal capillaries. In acute carpulmonale, there is a marked dilatation of the right-sided ventricle without the hypertrophy, and it is the crescent-shaped right ventricle. It is going to transform into dilated ovoid structure. In the chronic carpulmonale, the right ventricle is hypertrophic up to 1 centimeter or even more than 1 centimeter, and it may going to attain the thickness of the left-sided ventricle. Sometimes the secondary compression of the left ventricle or tricuspid regurgitation with the fibrosis thickening of the valve. In this picture, you can see that the right heart, it is dilated one because of the chronic carpulmonale, and it is also having the increased wall thickness.